So as you guys know, we lost more than 100,000 people last year due to opioid overdose. Alaska's opioid overdose rate doubled in 2021. Now, the tragedy is that almost all of these deaths were preventable. We know how to treat opioid overdose, naloxone and CPR, but you have to get people close enough to the people who are overdosing quickly enough for that to be an effective treatment. That's what we do. We build wearable devices to prevent opioid overdose. Let me advance my slides here. So I think one of the most tragic aspects of this is not just that it's reversible, but we know where these overdoses are happening. And worse yet, there are people at home who care about these patients, who are there in the home setting with them, and they just simply weren't aware that they needed help. Half of the people at home could have been saved. Half. Imagine how many tens of thousands of lives, how many tens of thousands of families didn't need to experience death from opioid overdose if they simply would have known. We built our system to make sure that if patients are in trouble, somebody knows about it. This system is very simple. It's a wearable device, a mobile application, and a cloud platform. We make sure that the patient is immediately diagnosed with overdose because they get to wear a device. We make sure that if there's somebody in the house, the device alarms and they can be responded to immediately by somebody close by somebody whom they trust. If they're alone in the house, or if they're far enough away in the house or apartment building so they can't be heard as an alarm, we send out a wireless alert. And this is linked to the phone, to the patient's phone. And the important part about this is that it is a stopgap for the alarm and for EMS, but it's actually the most trusted outreach for these patients. They get to decide who is called. Is it a friend, a family member, a sponsor? They get to decide who comes to rescue them. Now, in the end, if those people aren't available, or if they're too far away, or if, in the cases of places like West Virginia, where I grew up, or Alaska, the people are just simply too far apart, we also have a cloud system that makes sure that they can get help. And so we will be contacting crisis teams and EMS to make sure these patients get treated. Now, we know that if this was simply a tech problem, it would have already been solved. I think you guys have heard of a small company called Apple that might be able to do something about this. But they're not going to, because these are not Apple's customers. Apple doesn't want to be associated with medicine or with overdose, and they don't want to have insurance companies supply a $500 watch. This has to be a product that is given to our patients and covered by payers, but is also given to our patients and not noticed or attractive of stigma by the rest of the population. So we built our ARMband to be comfortable, to be absolutely private and secure, but to provide protection for these patients no matter where they are. We're going to be the first FDA-approved product. Now, we've been spending the majority of our time talking to patients, making sure the technology stack works, but we're also talking to the experts. And we've been backed by the NIH and National Institute of Drug Abuse. They've sponsored our research, they've funded stakeholder interviews, and we're currently waiting on a $2.5 million grant with NIH right now. We hope to get approved next month. But we're also engaging with the FDA. Obviously, the agency is the gatekeeper for all medical devices, but they're also the group who's most concerned with making sure that it does what it says it will do for everybody. So we want to make sure we don't just treat patients in the urban and suburban well-resourced areas, but we focus on patients in rural communities. We focus on patients who are traditionally ignored. We focus on patients who may not have a strong support network around them, but they still deserve to live. And in doing so, we think we brought FDA on board. We think we can get approval within the next 24 months. Now, we've also built a team that we feel can build this product. This is my third startup. My last one IPO'd at NASDAQ last year, Impel Neuropharma. We developed a brand new drug device product, and it was the first approved migraine product for its class. Our Chief Medical Officer, Dr. Desi Hite, has spent her entire career in emergency medicine treating these patients. Our Chief Technology Officer has extensive cloud experience and has guaranteed us the ability to transmit data reliably and keep it protected from anybody else's privacy violations. We've got a top expert in regulatory with us. They spent 30 years at the agency, and our head of hardware has built very robust devices in the past. But I think more important than their technical skills, our team believes in our mission, preventing fatal overdose. They also believe in our vision of ensuring everyone has access. To do that, we've really formed our company around this concept of a public benefit corporation that is a sole product. We do one thing: get parachutes out there to people, educate them, and save their lives. One product, one market. That is our sole focus. Being so solely focused lets us do a lot of things more efficiently and be able to really devote ourselves to this population in the form of public-private partnerships. Now, for us, again, if this was a tech problem, we would have solved it. It's not a tech problem. It's a tech problem, but it's a human relationship issue. We want to get feedback from the community, their experience using this app, their experience using the device. How's the wireless coverage in their area? How's the response time with their friends, their family, their EMS service? How do they feel about designated contacts? Even their friends and family, we've given them several different options of how they can relate, share their location, share their status. We want to encourage choice, because these are people who haven't had a lot of choices, usually by the time they need opioid treatment therapy. So we want to do all this, and we want to do it before FDA approval, because we want to make sure that this device truly is in the best interests of marginalized communities, rural people, mothers, Native populations. All of these groups need help, but we also need to show data that we can help these groups, because ultimately data is what drives payer coverage. Both Medicaid and private payers are motivated by us showing them we can save lives and save money. And that's what these pilot studies really do. And that's why we're here today. So we are looking for collaborators in Alaska for these pilot studies. We've identified several sites: Anchorage, Matsu, and Fairbanks, as well as groups like the Alaska Native Health Consortium and Alaska Mental Health Trust Authority. We believe you guys know these communities, know the patients, you are involved. We can't come in and tell you anything you don't already know. We'd like to have you tell us what you know and how can we help. So we're doing this with the notion of having a pilot study dedicated inside of our fundraising round. We have NIH money, we are raising private financing, but that's to get to FDA approval and to build the product in terms of hardware and software and cloud computing. I want to raise an investment round from impact folks that's solely dedicated to underserved community pilots. And for Alaska, we think this looks like about $150,000. Now, we believe that this can be a great example for other ESG investors, because I'd like to run a pilot like this in West Virginia with West Virginia impact investors. I'd like to run it in rural Washington State with rural Washington State impact investors. This will give us a chance to both touch the community and get their opinion, but also show them that we're going to be here for the long haul. We're not just going in after we have an FDA approved product and can sell them something. We want to get them involved in the development process before FDA approval. And so with that, I guess I'll actually turn it back over to Jacqueline and to the room with these questions. Given what we're offering, how can we serve Alaskans better? What are some of the opportunities and some of the real challenges that are unique to Alaska that we might not know coming in from the outside? We want to develop this with you. We want this to help your people, because that's the only way that we're going to be able to turn the tide of the opioid epidemic. Thank you.
First of all, thank you very much, Michael. That was fantastic. There's a lot of expertise in this room right now, and I'm hoping that I always have questions and ideas that I can contribute, but I'd like to step back and see if there's anybody who's on right now who'd be willing to ask some questions just based on their experience.
Oh, no, don't be shy.
Jackie, I don't have so much as questions, but one of the groups you've got to add to your contact list is the Alaska Behavioral Health Association, because we're the actual provider network.
Yep.
You've got some other good folks listed. Trust would be a good funder or investor, but I've already got an email drafted to all of the SUD providers I can think of that will go out as soon as I finish this
Oh, thank you, Jerry.
meeting. And Jacqueline, it involves you because they need to see this presentation. So I'll make a note that you'll post whenever it's available for them to come back and watch, because Michael and Des, we record these and people can
Sure.
go back and see them later. But it's the people that are actually in the trenches doing the SUD treatment.
Absolutely.
And some of the peer organizations as well. So thank you.
I was gonna say, Jerry, that's actually something we, in such a brief presentation, we don't have a chance to address everything, but we actually, in part of our I-Corps experience this summer, realized that the peer recovery support specialist network is actually the most valuable network in this space. And so we want to go in and not only make sure that the peer recovery people know about us, we want to make sure they're wearing us, because people relapse as peers too. And we want to make sure that people, I think, they're going to name their peer recovery specialist as their designated contact, more than mom and dad. That's, I mean, maybe their sponsor too, but specifically those peer people, that's the trusted group. And they also carry Narcan, they know the scene. I think the peers are absolutely essential to this, and the crisis outreach group as a mirror of that PRSS team as well.
Fantastic. And what I'll do afterwards, I was hoping that Jerry would step forward and share some of his information. So what I'll do after this presentation is provide an email introduction, and Jerry, absolutely, as soon as I have the recording available, I'll send it to you. And this is why we do these open innovations, is because we get these great community connections and we get these great ideas. So thank you very much. So Jerry, it's in your estimation, the peer groups and others are looking for solutions like this, and to have these conversations is one of the things that I love about the ARMband is it takes away some of the stigma that we're having this open conversation and trying to really put the focus on saving lives. Jerry, do you think it would align well with some of the conversations you were having through the Alaska Behavioral Health Association?
Yes, and I'll expand it a little bit. Michael and Des, I'll be in contact with you. In October, I'm part of the National Association of Alcoholism and Drug Abuse Counselors. We have our national meeting in Indianapolis. This is the type of thing that we need presented so that counselors know what tools are available to help them, particularly with people in early recovery that are prone to relapse. Here's a tool that we can implement. We did another one a year or so ago. It's called Dose Health, and that has to do with medication-assisted treatment. Well, here's another tool that helps in that process as well.
Absolutely. And I think as we look at, so if you look at statistics widely, alcohol use disorder is actually a leading indicator for opiate overdose in the VA system, more so than opiate dosing. And so there's a lot of, I think, intersection between mental health, treatment for mental health, and alcohol and other substance use disorders that lets us identify people who are at the highest risk and really get this out there. And again, there's no penalty to wearing this device. We don't tell on you if you use, we don't tell anybody else your behavior patterns, your movement patterns. We simply are there in an emergency. And I think that's what I'm hoping people in the mental health community will also accept us as this is an emergency device. And so it will provide protection rather than concerns about surveillance.
Jacqueline, you're muted.
Oh, thank you, Jerry. We have a great comment in the chat. It's from Julie. I'm happy to read it out. It says, Thank you so much for doing this presentation and the work you're doing. There is a huge need for this in Alaska and all over the US. Many of Alaska's communities are off the road system, far from hospitals, and have unreliable wireless connectivity. Can this device be effective in such communities?
Yes, so there's a two-part of this. One is technology. We are working on basically a wireless hub that will have a cell network connectivity in it. So for places that are off the grid, you could put it on there and someone could connect to it. The cell issue is a little dicey because to deploy that nationwide, you need 50 cell licenses. In places so we're actually looking at deploying it only in the places that need it, West Virginia, Alaska, for example. But the other side of this is I think we need to empower the crisis teams and the first responders in those rural communities. Again, coming from rural West Virginia, ambulance response can be 45 minutes, but the people down the road or over the hill might only be 5 minutes away if they know that you need them. And so usually they at least have cell communication or landline, kind of depending there. But ultimately, we think we need to not just notify the higher powers who need to get an ambulance to you, but just anybody around who can help rescue you. And I think that the cell phone area network on this is going to be a bigger thing in Alaska. And we would actually, we're looking to some more grant funded programs to see how could we do this in a way that will run a pilot, maybe. And so, because again, it's very geographic specific to which out of the way place you're going to, because out of the way in Appalachia is a different telco service than out of the way in Alaska. So there's a bit of a tech side, a bit of a patient side, but we think we can be helpful everywhere. And even just the alarm, I think it seems really hard to believe that we could save 40,000 people a year by just having an alarm. But really, if you're upstairs and your kid is downstairs with the door shut, that might be all it takes.
I think, Mike, you have a really important point there, and that is a lot of the current devices, even wearable devices, require the app and the wireless connection to determine that there's an emergency present. So their logic is actually on the app or in the cloud in order for the device to be small. But we understand that our users may not have that connection. And so our device has onboard logic, which means the internet does not need to be functioning for the device to determine that there's an emergency and to alarm locally. Now, obviously, we need to figure out how to do the wireless notification in the specific community, which is why we're reaching out for these pilots. We want to learn what the obstacles are and what the options are to overcome them to make the best product. And so that is still a learning process, but the device itself can alarm without any internet.
Absolutely. Very good point.
Oh, fascinating and really interesting to learn more about your decision-making process and why that is really different from what's out there and why this would be important for people to have. Julie, I really love your question, and it really sparked in me this idea that so often in communities, if you're first responders, you become knowledgeable of the people who need the services repeatedly. And so I'm starting to wonder if there might be a way to maybe work with first responders so that they could have the device and then maybe recommend that maybe some people that they've become familiar with might use it just so that they would know that they were safe or get called. Is that something you've thought about?
It is. Oh, sorry. Go ahead.
I'm going to let you answer. That's fine.
Oh, sure. Yeah. So absolutely. And both the crisis teams so everybody in the overdose movement, I think, is moving away from police and more towards crisis teams, both, cost reasons, personnel reasons, but also most overdoses are really, it's one medication, oxygen, if you want to count 2 medications, but it's a very simple protocol. So you don't need police. You generally don't need fire. You generally don't need an ambulance. But the notion, though, of how to bring them together so that we can provide these resources is really important. And I think so we would like to reach out to, say, EMS, because one of the applications can be if EMS is having frequent calls and they see the same person 10 times a year, they know that person is at elevated risk. And they can give somebody who's at very high risk a device, and that might save one life very, very effectively, more so than just scattering the devices out and saying, please pick one up. And so we think that the knowledgeable part of the community, EMS response, the mental health counselors, the peers, they know who is at highest risk because they've seen them overdose. And so absolutely, that's a critical outreach piece. And I would say further, Jacqueline, what I'd like to understand more is for the communities that are outside Matsu, outside Fairbanks, outside Anchorage, what is similar to West Virginia in terms of we have community health clinics, but we don't really have tribal reservations. We don't really have native lands. And so we haven't had to interact with that many, not regulatory bodies, but different groups who provide their own services to their own folks. I think one of the best ways is to go out and ask them, hey, how can we help you? If I gave you 10 devices, do you know which 10 people you give them to? How you, and it can be simple as that. I would like to know, because again, as somebody who's not native, coming in and telling people how to run their shop is not my idea of what's appropriate. They know what they need. I can give them a tool. We'd like to know, how can I help make this tool better for them?
Jerry, I would assume that many of the groups.
Right. Two quick responses there. One, Matsu, it's not Matsu, it's Matsu.
Sorry. Yep.
Is the size of the state of West Virginia. So just to give you an idea of the geography and how it relates here. Secondly, we don't have reservations and stuff. We have corporations, and it's one of the nuances. And I know I've already got Cody Chip from the Alaskan AD Tribal Health Consortium on the email list. I'm also aware that Nanilchek and Nakiski, I'm sorry, down on the Kenai Peninsula already has an opioid emphasis just because of the number of negative events that they've had. So I think this will move very rapidly with the offer that you're making, Michael. So this
Wonderful.
afternoon, the connections will be made.
Great. Thank you. Thank you, Jared. Can I ask guys what doesn't work about this? Like, what are the, again, obviously distance and telco is one thing. Is there anything that you're seeing that we're misidentifying on a mental health side or a cultural side? Is there something else about this that we need to just rethink? Is there anything that, again, I'm looking to apply this in your community. What doesn't work for you?
Alaskans are skeptical of anything from the outside of Alaska, like from the lower 48. So we've got to get a champion. Once we have a champion, it's proven, it takes off like wildfire. So that's the key. You're called Chachacos.
Yeah.
It's a local curve.
I agree. I think that the warm introductions, basically, I think you're very fortunate that Jerry was able to attend today, because I think the warm introductions from a trusted individual like Jerry will provide you with some open doors. The honest truth is that I'm not sure what doesn't work. I think it would really take this email and connections to Jerry's group and maybe a conversation with them to better understand, unless others on this call right now have more experience, but I'd say that Jerry's probably our most experienced person.
Great. I think relative to how we would provide a pilot site or otherwise, as we look at the process you guys go through, well, not you specifically, but the way you can imagine this rolling out in Alaska, what is the logistical process if you want to go through, is it an investigational review board to have pilot studies and there's a rubric around it? Or is there an opioid treatment program that's led by SAMHSA that use their IRB? Or is there a process, I guess, or is this sort of catch as catch can?
So Jerry's nodding because he's been with me right from the beginning.
Yes.
So basically, each one of these pilot projects that we've launched seems to follow its own path. So what I've learned, though, is that it takes 2 or 3 key people to make something exciting happen. So I think probably the next step would be to make these connections and to have a conversation and just get the feedback, and then see where your best champions are and continue the process there. That would be my recommendation.
Okay.
Jerry, anything to add to that? Or I see Nikki
We
might
just,
be
gotta,
out.
we just have to be persistent. People are very busy right now with COVID and demand for services and all of these things that are going on. So it's just being persistent in looking for those venues where we can get access and demonstrate the product. The only thing that I see that's going to be a challenge here for parts of the state is the connectivity.
Right.
So, but you're aware of that.
Well, and
When I say
think,
connectivity, the electronic.
right, the actual electronics. And I think this may be something where we try to frame the pilot if it's going to be something we know that is troublesome connectivity in a rural area. Maybe we focus the pilot around group homes or around multi-generational households or around multi-user households, even as long as there's somebody conscious and has Narcan present. There are different ways of showing efficacy to the various payer groups, but also the various patient groups, saying, look, this can work for you. And so I think we just need to know what those are, and we can try to, again, show people how it would work best for them. If they don't have connectivity, well, maybe we use it a different way. And I think that's again, just trying to find ways of doing that until the tech stack, either satellite phone or cell unit, can be brought to fruition, but I don't want to say that's easy. You guys probably saw the 5G fiasco we had down here with our airports. So there's all kinds of fun that you can have whenever you talk about telco.
Yes, that's true. But
Jackie,
again,
Jacqueline, I know we have 1 minute left, and what this may need is a follow-up presentation if we can get the band together of interested individuals where they can see this for themselves.
sure. Yeah,
Absolutely.
I will follow up with you, Jerry, and with you, Michael, after this, and Desi to do that. So you're absolutely right. We're pretty much out of time. We do have one last comment that I'd like to share. It's from Doug Franklin, who is also an entrepreneur and knows about building technology. And he said, I'm sure you've already thought about durability concerns, but being a subarctic environment means folks are often wearing heavy long sleeve garments, making sure the subcomponents on the band are rounded so they don't catch, and that the flex PCB or whatever it is that connects them does not tear are important factors. Wow, that's
Absolutely.
really good.
100%.
Yeah,
what you see on the right-hand side here is our prototype pilot. The finished device will have none of these components visible. It will be overmolded with plastic, and it will be thermo-tested down to about 20 degrees below. Because yes, we are concerned about that, and we want to make sure that as this is worn underneath clothing, t-shirts to full subarctic gear, nobody notices. That's the best thing, is it's super light, it's very comfy, and that's what we want to get people in used to, is just the habit of daily living. You put on your parachute and go on about your day. That's really what we're targeting. But great comment, definitely.
Thank you so much.
Concerns is exactly why we want to come to Alaska. Obviously that won't come up on the Florida conversation.
Exactly. Awesome. Thank you, Desi. Thank you, Michael, very much. Wonderful presentation. Thank you all for coming today and for your excellent questions and feedback to ParachuteDx and about the ARMband. Obviously, there'll be some follow-up. We have